So here we are in the middle of summer in Basingstoke. It's very, very warm, and Phil has come all the way from Leeds for our afternoon program on the pathology of rectal cancer. Bill is going to tell us a little bit about Phil and how we've met and how we are here today, and the importance of the whole relationship between pathology, surgery and radiology. Bill.
Actually, Phil met the specimens I was taking out of my cancer cases. Cancer of the rectum was a cancer with huge variation between the surgeon to surgeon, so that some people were curing half their patients or less, others were curing 3/4. And what was the reason? And I became very interested in this during the late 70s and 80s, and started to talk about total mesorectal excision. And it wasn't really till the end of the 80s that Phil, who'd been taking a great interest in exactly what the surgeon takes out of the patient, its margins, its detail, why is it the shape it is, and why are the failures occurring in a particular place, and all of those things. So Phil and Bill, that's him and me, became a sort of traveling circus. And later on, Brendan was all part of us too, and became, of course, the most energetic part of us, perhaps. But anyway, here we are in Basingstoke, as Brendan has just said, and Phil has come back to take a look at what we hope we achieved between us. He was really the first man, I think, who dared to look down at a specimen and suggest to the surgeon who was looking round in a group of doctors that maybe the surgeon didn't do it as well as he should have done. And that was a really something that never happened to surgeons, who all tended to think they were God, and the idea of God having his work criticized was a very unusual one. So he's a great man. He's changed the practice of surgery, cancer surgery in particular.
So, we first met 30 years ago now, so in 1991, across a rectum that Brendan had brought over on the plane, and it was the close relationship that we developed between me and the surgeons that enabled me to see that these holes in specimens and defects, actually potentially some surgeons didn't make them. So it was only through meeting these guys that we got the insights that we did. So multidisciplinary working all stemmed out of those sorts of meetings.
Of course, Phil, you started off with the famous paper from Leeds, where you identified that if you had tumour at the edges, you had a very high local recurrence and poor survival, and that was the forefront, wasn't it? Tell us a little bit about that paper.
So, so Bill and I were working completely independently. So I was pretty amazed when I saw his paper come out in 1986, which was clearly the evidence that he had a phenomenal survival and a phenomenally low local recurrence. And he'd said, this is how I do it. We've been working at the same time, and we had data which was the explanation for why good surgery made the difference, because we could see the tumour at the margin of the specimen in 36% of the cases, and at least 80% of those patients died, not surprisingly, because they developed local recurrence. So it was Bill's paper coming at the same time, or just before our paper came out, both in the Lancet, which gave a bit of an impetus to the area.
Because that was with Norman Williams, who became subsequently very well known to all of us. Norman was in that paper, wasn't he?
Yeah, Norman was the professor. No, he was a senior lecturer in surgery at that stage. He wasn't, and Mike Dixon, of course, who went on to do some other great pathology things.
And I think what you have really achieved is you are a surgeon's pathologist. I know Bill said you challenge us, which is really good, and I think that's really important. But you have adopted the whole surgical anatomy of the rectum and the rest of the body, and you've taken that into a new level. And the whole aspect of TME, anterior resection, abdominoperineal, complete mesocolic excision has come from your combination of your surgical pathological approach, hasn't it really? That's how we've got to where we are.
Well, I mean, it's come out of learning from the surgeons. So firstly, Bill taught us which planes to follow. So we then get to look at the planes of different surgeons that they were following, and they were following different planes.
Or no planes.
Many of them were following no planes, which is what the problem was. And the major problem was the training. That if your boss was great, you would get great training and you'd be likely to be a great surgeon. If the boss wasn't quite so good because they'd been trained badly to start with, then of course you got a bad training and therefore you're a bad surgeon. So it's not the surgeon's fault necessarily. The issue is, have they been trained well, and was the person who trained them actually doing the right thing? And anatomy has come down to be the fundamental of it, and I only got into the anatomy because of you guys and your close associations with Chummy, who was an anatomist at the Royal College of Surgeons, and subsequently other anatomists, and we've learned an enormous amount from anatomists as to how we should be doing these things properly. And that lesson has moved on into low rectal cancer, into colonic cancer, and is fundamentally important to surgeons. And surgery is fundamentally important to the cure of this disease because it is a relatively localized disease for a relatively long time, and then it has a relatively small number of metastatic pathways, so it's very different to other diseases. So this is the perfect surgical disease.
Okay, you've got some wonderful slides, Phil, so maybe we could move on to the slides and see what you've got on that. You've got some fantastic slides, we've looked at them before. And I think when I was growing up in surgery, we talked about some of the famous names in pathology, and I know you've got the next slide is going to tell us a bit about the development of rectal cancer pathology.
Okay, so I mean, we all build on the shoulders of giants, and what we've learnt and our views are learnt from other people. But it's very amusing to know that Cuthbert Jukes would have been very careful about choosing the surgeon to do his operation. He also added in that quote that he'd make sure they had a good breakfast, which I think is equally as important. And of course, Cuthbert Jukes was replaced at St Mark's by Basil Mawson, and Basil was an excellent pathologist who did the adenoma carcinoma sequence, did a lot about inflammatory bowel cancers. So these are giants in the field, and Jukes did Jukes staging. That's been surpassed by TNM staging, and we've been through a whole variety of different protocols, and we've now got pretty good staging, but also we note everything down and protocolize it, because that's clearly going to enable you to do something consistent.
And the interesting thing about Jukes, though, was it was simple, and it was three things. It was A, B, and C. And actually, for the surgical surgeons...
That's still where they are in America, really, 1, 2, 3, but they put in a few subgroups.
And my interpretation is it was an amazing development to say, like the good, the bad, and the ugly in the Mercury that Ian Daniels came up with. 1, 2, 3 is quite useful. The huge benefit, of course, of TNM is that you can, tumor node metastasis, is you can estimate these stages preoperatively, and we've covered that a little bit with Gina Brown. So I think that this is where TNM has been very useful, Phil, hasn't it? You can estimate what it's likely to be by imaging. Whereas with Jukes, it was very much when you took it out and you put it under the microscope, it was A, B, and C. And of course, it still is. It still is really important, because without the pathology, you don't really know.
But the T focuses on local spread, which is clearly incredibly important for rectal cancer. The N concentrates on metastatic spread, which is really important in terms of your risk of distant metastasis. And of course, the M classification is about metastasis. So, I mean, these are key features. I mean, one thing I would take issue with the radiologists is that they mustn't be too wedded to pathology staging, because they're not pathologists, and they aren't particularly good at lymph node involvement, but they are very, very good at T stage, and they're also very good at extramural vascular invasion because they can see through more than one plane. So radiologists need to prove what they're good at and deliver that to the surgeons, so the surgeons can make the decisions about what they're going to be doing about that any individual patient. But that link between the pathology and the radiology, as we'll see later, is really important and helped us to get a preoperative imaging, because getting the answer from the pathologist is usually too late. Getting the answer from the radiologist can be helpful.
Gina tells us it's so much more important than lymph node involvement, and I'm perfectly prepared to, I mean, it's common sense in a way that it's likely to have greater danger if cancer is in a vein going towards the liver or elsewhere. And so it's easy to buy Gina's argument, but unfortunately the 1, 2, 3 ABC staging doesn't really cover it at all.
I mean, there is a venous invasion classification for for TNM, so you can include it. But lymph node involvement is still important.
You better tell them how.
Well, I mean,
4C.
You add V0, V1, so and there's V2 for large vein involvement. So you can include venous invasion in in a TNM classification. I think that there is still debate about the absolute importance of vascular invasion and the types of vascular invasion. It's important, but Gina says it's absolutely the only thing that's really important. Well, lymph node involvement is important, but actually probably what's most important is how many different modes of spread have you got. So if you've got vascular invasion, lymph node invasion, and you've got neural invasion, then you've got you've got 3 different methods of spread plus peritoneal invasion. So they're all important, but the more you've got of them, it's much worse. So we haven't got very good sub-stratification for these sorts of things, and that's because to do that you need thousands of cases radiologically and pathologically, which have been done by an expert radiologist, an expert pathologist, and then you do the multivariate analysis.
And you need a lot of long-term outcomes.
And you need the long-term outcomes.
Should we move on to the next slide? And so in the 1980s was really where the whole aspect of TME was popularized and developed by Bill. And so Phil, you tell us what you were looking at in those days.
So unfortunately, well, I mean, this is what the surgeons looked at. Unfortunately, in the old days, this was actually common. And you get these horrible local recurrences, one of the worst ways you could possibly die, and 20 to 40% of patients would get them. And of course, there was a lousy overall 5-year survival from the combination of the local recurrence and the metastatic disease. And then we had the surgeons who, in the textbooks, were still suggesting you should avulse the rectum with your hand at that stage. And then you have Bill coming along with his very exquisitely sensitive anatomical removal of the rectum with TME, which was transformative. And then we came along because the pathologists were always looking at the distal margins, and that didn't explain why we had so many people, 25 to 30% of people were getting recurrences. And what we could do, within the first 5 specimens that I ever cut through, sliced across, one of them came up with a positive margin. And the more you did, the more you saw. So over a third of patients all had cancer at a margin, which was a basic pathological principle. That's bad news, and you ought to be reporting that to the surgeon, but nobody ever did. So the nice thing about this paper, though, was that we actually had the outcome data for it, which showed that you had a very high rate of local recurrence with this sort of situation. So the survival was reduced from 80% to 30%, less than 30% if you had an involved margin. So not good. And then that was a very arduous methodology. We managed to go on and just do a simple histopathological inking, cross-slicing, and looking on standard slides to see whether we could see the tumour. And of course, we came up with exactly the same margin positivity rate and exactly the same slides of local recurrence and survivals, and that was in the Lancet in 1994. So that took us 8 years to
the dramatic differences in those. If you look at those two graphs, the dramatic differences in local recurrence and in survival.
Absolutely,
which profoundly could not be. There's no drug could change that.
Absolutely, no drug that does that, and it's all about something. You've got to do the surgery. You can do it well, or you could do it badly. And the vast majority of surgeons at that time were doing it badly because they didn't know and they hadn't been trained. So Bill's huge contribution was actually defining that anatomical approach, but it was also the enthusiasm with which he took this on and tried to help other surgeons to get better. Because I'm sure there were surgeons who were probably doing similar anatomical things because they'd been taught that way, but they didn't actually, A, prove the difference, and B, they didn't go on to teach it and change the outcomes for rectal cancer patients around the world. So hugely important, but it was nice to be able to give the reason behind why we were having such a problem, and that was margin positivity, but also the fact that if you didn't take it out properly, like you guys did, of course you got a much higher rate of margin involvement. And this is a video which shows the first time when I met Bill and Brendan, and you see that big gash. That's purely because of the way the tumour's been taken out, and that can be a death sentence to somebody if when you should have been at least a centimetre away from that tumour. And what will happen in that picture in a minute will be that we'll see a Bill specimen brought by Brendan across on the plane, and so we did full cross sections, and we did these full cross sections basically because Bill was there, and Bill suggested we should do the full cross sections, so we did.
It's interesting that I gave the specimen, which had been informal, to my senior registrar to put in his bag. I didn't bring it in my bag. But anyway,
so when Brendan was arrested, you could leave him behind. But
Exactly.
that's the whole cross section, which Bill suggested. Well, why don't we do it that way? So we did, and we stopped opening the specimens after that. And you can see that tumour's well away from
And a very nasty.
Yes, a nasty cancer, but it's got 5 millimetres around it, and so it's doing much better. So simple anatomy, a bit of pathology, and the surgeons knowing how to do it has made such a big difference. And it comes down to you mustn't be avulsing the rectum with your hand. You should be doing it properly with very careful anatomical dissection. And it was from looking at these specimens that we developed a system for saying something was on the muscularis propria plane, so it was on muscle, which it shouldn't have been. There were bits missing from the mesorectum, intramesorectal, and then a beautiful specimen on my right-hand side, which basically shows the fascia, the anatomical planes, and a perfect
That's
specimen.
an unfixed specimen that had just come out of a Basingstoke abdomen and is shiny, which is one of the clues for the surgeon, is finding the shiny circumferential margin of the mesorectum.
Absolutely.
But what you developed, Phil, with this system was you had the 3 categorizations, going back again to the good, the bad, and the ugly. And what you were able to show was that we should, as surgeons, be aiming for a really good specimen. And if we got a really good specimen, you were seldom disappointed by having an involved margin in the pathology. And so what you could tell is that if you looked at those 3 specimens, you're very likely to have a clear margin in the shiny specimen, and the other specimens, the really bad one, you're very likely to have an
Well,
involvement.
in the shiny one, it'd be 3%, and in the other one over on the left, the muscularis propria, it'll be 18 to 20%, if not higher. So it makes a huge difference. And just by looking at a few specimens from a surgeon, you generally get a good idea about, have they learnt the planes to go down? And if they haven't, then you turn them over to Bill or to yourself.
Of course, there's a good common sense reason why the specimen is shiny and the shape is the same, pretty much the same from most people. And the reason is embryology, because the gut from the mouth to the anus is a midline structure with the blood supply coming from the front of the aorta, whereas it's surrounded on all sides by paired structures with, for the most part, laterally flowing arterial supply. And likewise, the venous drainage from the whole of the abdominal gut is to the liver largely, and hence the commonness of secondaries in the liver from colorectal cancer.
So Phil, one of the aspects that Bill and I wanted us to discuss is the whole aspect of quality control and assessing the quality of surgery. And you've actually stuck your neck out quite often and said that this you have to do better. And I remember when we ran the program in Denmark, one of the things that Soren said, we must do better. We can always do better. And I think that's what you've driven quality control. And so, would you like to tell us a little bit about where this has taken us, this concept, maybe on the next slide, I suppose?
Well, so, I mean, firstly to say, I can do better. And I'm sure Bill can do better. Yeah, we can all do better because we're not 100% of the time. But, for Bill to improve his surgery, it's a really, really small bit. But he still continues to try, or did whilst he was still doing the surgery. And I'm sure you still try to do a better job each time. And that's the only thing that you can ask of somebody. Firstly, they've got to understand what they need to do and they need to be trained to do it. And then they need to try and do it better and better each time, because it's really important. If you make a slip up, you could lead to a person getting local recurrence and a person dying. Surgery is a really important job, and it didn't always make me very popular, but it's so important that you just have to put up with some of the aggravation sometimes, because I think we had really good evidence that actually it made a difference. So, I mean, some of those cross sections that we did, we can see so many things on those cross sections. You can see if there are chunks of the specimen missing causing the margin positivity. You can see if it's a bad tumour. You can see vascular invasion. You can see nodal invasion. You can see the extent of spread out of those tumours, and you can see peritoneal involvement. So the very fact that the radiologists started to see these specimens led to a Scandinavian Swedish radiologist actually MRIing one of the specimens. And it was amazing. You could actually see the pathology in the specimen. And that led Leonard to actually do it in a patient. And so he set off the whole trend of MRI. Gina Brown came along and developed it. Bill saw her her interest, enthusiasm, and Gina really embraced it and developed the MRI tremendously, such that now you have your preoperative pathology, which is fantastic. And it went on to, so it's this leapfrogging thing. When a team of people get together, you meet in a multidisciplinary fashion. And so from the rectal cancers, we went on to identify actually that the abdominoperineals hadn't improved with TME. And so looking at all of that anatomy and looking at the radiology, so you could see what the surgeons could or could not remove, and then linking up to friends of that Bill and Brendan had met, so Torbjörn Holm in Stockholm, showed us alternative ways of changing this problem with the circumferential margin in the abdominoperineals. So it's all about the anatomy at the end of the day. So the mesorectum is a nice big bulbous fatty set of tissues through which the rectum runs, and there's quite a lot of tissue you can take out, but you have to take it out properly, as in the lower panel. But once you get down to the sphincters, then of course the mesorectum cones in, you have the sphincters coming in, so the tissue is a lot less, so it's much more dangerous with margin positivity. And Torbjörn came along and we looked at his specimens. Brendan and Bill recognised the importance of this. Nick West did some pathological studies for his PhD, and what basically was happening was that in the old style fashion, surgeons were coming down the mesorectum and they were entering into the sphincters, and so there was no clearance for those tumours, and there was still a bit of variation around those, but really it left very little clearance, whereas Torbjörn would come down onto the levator, stop there, and then he'd operate from below to get as much width as he needed, given the MRI having defined what the extent of spread was, and he'd either go closer or he would go further out, dependent upon the tumour. So you end up with MRI staging the tumour and the surgeon determining the plane that they're going to operate in, and then if the surgeon operates well, we then get down to very low rates of margin positivity, which of course improves the survival in this situation. So the links between the surgeons, the radiologists and the pathologists were transferred from the TME down to the low rectal cancer.
Can you ever see a time when radiology will define what we now call pathology? Because Gina would say that actually she can see more than the pathologist. But I think one of the most important papers that we all combined wrote was that little paper where we say that if you do an MRI or a CT scan, you should not call that T staging. It has to be MRT, MRN, because it's a correlation. The real TNM is pathology, isn't it, Phil? Gina would tell us that actually perhaps the radiology is better than pathology.
So TNM is a pathology staging, and we use it because it has clinical correlates. So we know what the survivals are, we know what the local recurrences are for any given TNM stage. So I would agree with her that she ought to develop an MRI staging process, but that MRI staging process needs to be associated with all of those clinical parameters, so you as surgeons know what's going to happen to that individual given that MRI staging. Now, Gina may be better at looking at extramural vascular invasion, and it's certainly better because it looks at the specimen before you've taken it out, so it means you can do something about it rather than it being too late. But Gina can't see individual cells. Her resolution is much less than that, and so she isn't as good as pathology in some situations, but she has a hell of an advantage because she does it preoperatively.
But I think especially in low rectal cancer, and this picture shows it, what MRI has given us, you can picture the anatomy, the difficulty in removing that, and of course a lot of these patients have chemoradiotherapy, but the tumour is still present. And the problem, even if you go through fibrotic bowel, you will spread cancer cells, living cancer, and you create infection, and that promotes. So I think MRI is really useful for low rectal cancer because it gives you an idea what the sphincter and the levators look like. And actually, the concept of extra levator abdominal vein excision is something that we developed with Torbjörn, in conjunction with you and Gina, because what you're doing is you're operating outside the levators, which come down and form, are part of the external sphincter. So I think for this particular aspect, I think MRI has been very helpful, and correlating that with pathology, clear margins is really important.
The big thing that Phil emphasized to everyone, and they all knew that it was true, when they did an abdominoperineal before he got really interested, or we did between us, in why our APs were doing worse, he talked about the waist. He's already mentioned the waist, and we've seen one, but the waist essentially was where the levators meet the external sphincter. and down there is exactly where the cancers are that you have to do an abdominoperineal on.
3 or 4
and that's why we were getting such bad results, and we must have the levator right the way out to the origins on the pelvic sidewall to wrap the bottom bit of the mesorectum.
But I mean, but that gene is also, you know, makes a major contribution by the post-radiochemotherapy response. So, you know, you can see those tumours, some tumours completely disappearing, which allows the surgeon to watch and wait. So, you know, pathologists certainly can't do that. And also knows when it's not responding and it's growing, and therefore you have to go further out. So, you know, radiology is tremendously important. It's getting better. They will get higher Tesla machines. They will get higher resolution, and they'll get the impact of special dyes at some stage, hopefully. It's been a few years since that one's been around. But so radiology is going to get better, but we need excellent trained radiologists, because it's like the surgeons, you know, the skill is in the surgery, the skill is in the interpretation by the radiologist of the radiology. And ultimately, the skill is in the pathologist. So we need highly trained multidisciplinary teams to manage what is an eminently curable cancer in many situations. And we can't say that of many of the cancers that we all have to deal with.
I still think it's quite amazing, because I see this fairly regularly, is that with the most sophisticated imaging, you know, functional imaging with PET, sometimes it's completely wrong. It's a complete false positive, because you can get an inflammatory condition, looks like recurrent cancer, and time again we see. So I think there's always a need for pathology to confirm some of the findings that we're predicting it.
What about radiomics? We haven't, I mean, we know there's an awful lot of data in an MRI which we don't use to get the pictures we look at. Is there anything you can use as a pathologist? See, I mean, it's a sort of fishing trip for other things we might learn, some of the things that you can identify later when we've taken the tumour out. Can you see the radiomics coming up with some new magical information about the true malignant potential of a tumour, for instance?
So the potential for radiomics is huge. So feeding a computer a large number of annotated MRIs for which we know the outcome, we know the definitive status of those lesions. So it's potentially huge. We haven't seen it yet in this particular situation, but what we need are large data lakes of MRIs which have been annotated with great outcomes. And I think it's got a huge potential to help out, and especially in that situation, has the tumour all gone or hasn't it? Is it
after chemoradiotherapy?
Yeah, after chemoradiotherapy. Yeah. Is that inflammatory adhesion or is it cancer adhesion? Because there'll be bits in the image which we can't interpret because we haven't learnt how to do it, which will help the machine to actually understand what it is. But you need to have validated these programs. There'll be loads of programs coming out saying, I can do this, but actually it's got to be properly validated, and that needs a huge, big effort. So I would strongly suggest that radiomics is a very important potential area, but it's still in the early days. And I think I'll come back to AI and pathology later on to show that actually we have moved on a bit there, and we can show that it potentially is of value to us. But we're yet to see the true value, but I would put some money on the fact it's going to be important.
You can find a whole series of videos and links to our series of discussions around rectal cancer at this address. And if you have any suggestions what we might cover, please let us know. Thank you very much for joining us.